It's good to see you all this afternoon. Make sure everyone's unmuted. If you could please mute yourself and keep yourself muted for the duration of our program today. We want to thank our sponsors, Bircham Hills and Diamonddale Nursing Care Center, along with our inspiration sponsors, Ingham County Medical Rehabilitation Facility at Dobie Road and Lansing Board of Water and Light. My name is Katie Hubbard, and I'm here today with Amanda Richard. Amanda is a respiratory therapist at Sparrow, and she's been with Sparrow for over 20 years. So I'm really excited to have her today to talk with us a little bit more on the topic of asthma and COPD as we continue on our chronic conditions series. So just a couple of reminders, if you have questions, we'll take those at the end. You can type those in the chat bar, and I'll just be collecting them for her, and we'll get to as many as we can within the hour. So without further ado, I'm going to go ahead and turn it over to her. And we'll look forward to learning a little bit more together.
Hello, everyone. As she introduced me, my name is Amanda. I'm one of the respiratory therapists at Sparrow Hospital. Been a respiratory therapist for almost 23 years. It's something I highly enjoy, and I'm very excited to be here to talk a little bit about asthma and COPD. Sorry about that. Zoom meeting, I'm really good like in person. Zoom meeting, this is my first, so you have to bear with me. All right, so today we're going to talk about understanding COPD. So the easiest way to really understand COPD is to first off start with it's a little bit of an anatomy lesson, okay? So we are going to talk about the anatomy of your lungs. And that really does help us kind of learn about what diseases can affect your lungs. Little technical difficulties.
Yeah. I'm going to pop on and mute a few of you real quick here. If you could mute yourselves, though, that is super helpful. We have a call in to try to figure out how to keep everyone on mute, but until we get that figured out.
All right. Okay, I think we got the technical difficulties figured away here. All right, so as you can see on my little picture here, you look at your lungs. If you think about your lungs are cone-shaped organs, and they're actually your largest internal organ that you have in your body. So if you can kind of think of your body, your lungs actually go from your shoulder blades to the very bottom of your rib cage. They're kind of cone-shaped. Your right lung is actually a little bigger than your left lung, and that's because your heart kind of sits a little bit more towards your left side, so the left lung's got a little bit taken out to fit your heart in there, okay? They're protected by your ribs, which I'm sure you all knew that. The cool side is your right lung actually has 3 lobes, where your left lung only has the 2 lobes, and that's because, again, your heart's kind of sit there. But inside your lungs, if you kind of break your lungs down as you go through, you can kind of picture, if you guys can see me, you have your upper airway. So as you take a deep breath in, all that air goes right through your windpipe, which is your trachea, and branches off to both sides of your lungs, okay? So from there you have bronchi and you have bronchioles, which are the tubes that go from your windpipe way deep inside your lungs, because it's kind of like little road maps for the oxygen to follow. The goal for these, obviously, is to have air come in and out of your lungs. At the very end of your lungs, as you can kind of see in my picture here, we have little kind of air sacs. If you can kind of think that your lungs kind of look like bubble wrap, for lack of a better word. A whole bunch of little tiny air sacs that you could kind of pop, okay? So what these air sacs do is as the air comes in, they get big. As the air comes out, they get smaller. All right. So you can kind of, what they do is help feed oxygen into your blood, and they remove the carbon dioxide. So you can kind of see on my picture, you have the blue blood there. That is deoxygenated blood that you're breathing out. And they have the red, which is oxygenated blood, which is going into your body. The cool thing about your alveoli, you have over 3 million alveoli in your lungs. It's huge. So if I were to actually take all of those out and spread them, they actually would cover a whole tennis court. So there's quite a few alveoli in your lungs. All right. Okay. So as we go through our lungs, all of your I have this one a little bit different, but let's talk about the mucus first. So mucus, everybody kind of knows that's that sticky secretions that you kind of cough up. But really, mucus is a normal part of your lungs, okay? The purpose of mucus is it helps trap that air, that dust and the smoke and all the smog and all the allergens that are out in the lungs. Kind of acts as a lubricant so that your lungs are a little protected. And if you get any of that inside of your lungs, to cough it out, actually the mucus is good because it helps prevent from infections from forming. Okay, but to make that mucus move, you can kind of see my picture here. There's little cilia. So cilia are kind of little tiny hairs that move like my fingers are moving inside your lungs. Okay, so as that cilia moves, what it does is captures that mucus and it helps bring the mucus up so you can cough it out. Okay, now the bad side to smoking actually stops that cilia from moving for up to 4 hours. So one cigarette stops them from moving for 4 hours. So as those don't move, what do you think happens to that mucus? That mucus just sits in your lungs and becomes cement and becomes hard. So 4 hours, it starts moving again. You start coughing and you start producing mucus. So that's why people that have smoked for a long period of time that all of a sudden stop, their cilia slowly will start being little finger-like projections again and start moving. That's why a lot of them start coughing and they cough up a lot of secretions and they say, oh, I'm worse with not smoking. They are worse because they feel worse, but in reality, it's their lungs cleaning all that smoke out. So as we talked a little bit about the lungs, so let's talk a little bit about COPD. So when people think of COPD, they pretty much automatically think of emphysema. So actually COPD stands for chronic obstructive pulmonary disease. So there's actually 4 different types of diseases that kind of fall under the heading of COPD. Emphysema is probably the major one. You also have chronic bronchitis. And asthma actually falls under the header for COPD, okay? And we'll talk a little bit more in depth about those 3 diseases. And then cystic fibrosis, which is a chronic disease that people are born with, also falls under the COPD header, but something that we're not going to talk about in this series. So let's talk a little bit more about emphysema itself. So emphysema is a condition, where those air sacs, so the bubbles in the bottom of your lungs, they actually become stretched out. So if you can kind of think of a balloon, I should have brought a balloon with me. As you blow up a balloon, it gets nice and big, okay? You let the air out, it's gonna go right back to being small. But the more times you blow up that balloon, it loses its elasticity, so it doesn't fully go back down. So that's what happens with emphysema. Is those air sacs, over time, do not go back down to small, so they kind of stay enlarged, okay? So what happens when they stay enlarged? Couple things are going to happen. One, you're not able to exhale all that carbon dioxide out of your lungs. So inadvertently, you have less oxygen. Okay. And also, over time, your lungs, which I talked about being cone shaped, they actually become flat at the bottom. So where a nice healthy lung, you breathe with your diaphragm, so you breathe in and out kind of like this. People with emphysema, their diaphragm becomes more of a pan shaped. So it is not able to help them breathe. So they start breathing with the muscles up here, okay? So when the air sacs are not completely empty, basically, like I said before, they call air to become trapped, which makes it harder for you to get oxygen in and out of your body, as well as carbon dioxide in and out of your body. Chronic bronchitis, and I would say a lot of times chronic bronchitis and emphysema kind of go hand in hand, but there are people that have chronic bronchitis that don't have emphysema components, okay? So chronic bronchitis, I'm sure a lot of people have had bronchitis. So what differentiates chronic bronchitis versus normal bronchitis? So chronic bronchitis is that you've had it mucus for most days for at least 3 months in 2 consecutive years. So if you've had a bronchitis where you're producing mucus for a 3-month length for 2 years in a row, you kind of fall into the chronic bronchitis heading. So a little bit different between chronic bronchitis and emphysema. Chronic bronchitis actually kind of more affects the airways, so those bronchi and bronchioles, versus the little tiny air sacs at the bottom. So what it does is the mucus, because the cilia aren't moving like I kind of said earlier, gets stuck on those airways. So you can kind of see on my picture over here, what the inflamed and the airways become narrow. Well, kind of just like any kind of road, if you have congestion of traffic or an accident, the traffic doesn't move as smooth. So your air isn't moving as smooth in and out of your lungs when you have chronic bronchitis. And then the third one, which I'm not going to focus too much on asthma, but we'll talk a little bit about asthma. So a lot of people think asthma more of a childhood illness, which in theory it really is more of a childhood illness in the sense of that's when a lot of people are first diagnosed. So what asthma does is that the tubes, again, kind of like bronchitis, so the tubes that are carrying the air actually start squeezing down. So you can kind of see on our picture over here, you see a normal airway is nice and big and open. And in asthma, the airway squeeze down. And they also got a lot of inflammation inside their lungs. The big difference between asthma and the other two COPD, between chronic bronchitis and emphysema, is asthma is reversible. So I can give medication and my asthma will actually go back to normal airways. So when a doctor's trying to differentiate if an adult has asthma versus having emphysema, they're going to differentiate by a pulmonary function test, which I'll talk about in a little while. They'll differentiate if it's reversible with a bronchodilator. So diagnosis. So how do we diagnose? Really, the main way to diagnose any kind of a COPD is with a pulmonary function test. I don't know how many people out here have had one before, but a couple different options. Some people have had them inside their doctor's office where they give them a little blue device and they have them take a deep breath and blow super, super hard and super, super long, and they're yelling at you and you feel like you're going to pass out because you're blowing the air out too much. That is called the handheld PFT. Probably a more advanced one is a body box, where you can kind of see my picture over here. They put you inside this big, huge box, and they plug your nose, and they have you hooked to this machine, and they have you do a whole bunch of different breathing techniques, where they have you breathe in and out, and then they block you out, and then they have you take a deep breath, and they yell at you to blow, 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 blow. And it probably takes a good half an hour to 40 minutes to fully complete, because after doing one, they're actually going to turn right around and they're going to give you a breathing treatment, and they're going to completely redo the test again to see again if you have that reversibility, to be able to clarify if it's emphysema versus asthma. And then obviously through your doctors, they might do a chest x-ray, they might do a CAT scan of your lungs to see if there's any kind of scar tissuing, lab work, things like that they'll do also. So we always talk about signs and symptoms of COPD. And these signs and symptoms kind of really go across the board, whether you have emphysema, chronic bronchitis, or asthma. A lot of times you have all of them. The symptoms are interchangeable. So you get shortness of breath, especially during physical activity. Wheezing, so that's that whistle sound. When you take a deep breath, kind of like that. Your chest will feel tight. So a lot of times people that are having an exacerbation or having issues will feel like they have an elephant sitting on their chest, so they can't take that deep breath in or deep breath out. A chronic cough, that's really common with all three of them. And they may have mucus production, which I had said earlier is somewhat of a normal. As long as that mucus stays clear, that's the body doing its job. But when it starts getting white, yellow, or green, that's a sign of infection. Frequent respiratory infections, lack of energy, just because they're not able to get enough oxygen, which you think of oxygen as the fuel for your body, just like the fuel for your tank of gas. There we go. Okay. So we're back to looking at energy. Let's see. Unattended weight loss. This is especially in later stages. And then swelling of your ankles, feet, or your legs. Those are all kind of big symptoms. Now, granted, those can be symptoms of a lot of illnesses, but these are big symptoms of COPD. So exacerbation. So let's talk a little bit about exacerbation. So people with COPD are likely to experience episodes that they call exacerbations, which their symptoms become worse than usual from day to day. So what I'm going to show you next is kind of what we teach our COPD patients that we do education on in the hospital at pulmonary rehab, is we teach them a stoplight version to be able to show you how to manage your COPD symptoms. So the first one here is your green light. So when you see the doctor, you want to think of a stoplight, like I said before. So sorry, I totally got myself off train of thought here. So green zone. So your green zone means your symptoms are under control. You have good activity, your normal exercise amount, you have the normal amount of mucus, a normal cough, you have no change in your sleep habits or your appetite. So if you're in your green zone, you're really going to continue to drink water. You'll use your oxygen if you're prescribed oxygen, and definitely avoid cigarette smoke, whether it's from you or from secondhand. So your next one that you have, that you'll see, is your yellow zone. So your yellow zone, this is where we're kind of, okay, I'm starting to have some trouble. So what do I need to do at this point? So the first thing, your symptoms would be become more breathlessness. So getting up to go get a drink of water is a little bit harder than normal. You have less energy. You just don't even feel like getting up to make dinner. You're having more coughing, or there's a change in your mucus color. So if you have the normal amount of coughing, but all of a sudden you're have changed from being clear to being yellow, then by all means you need your temperature greater than 100.4. If you have what you consider a chest cold, if you're feeling that you're taking extra breathing treatments and they're just not helping you, or your appetite is not very good. Those types of things means you're in your yellow zone. So what should you be doing when you hit your yellow zone? Continue your medication and your oxygen as the doctor has ordered. However, we're encouraging you at this point is to give your doctor a call. Whether you give your primary care doctor a call, whether you see one of the pulmonologist group, give your doctor a call and say, you know, I'm in my yellow zone. And I can promise you most of the doctors understand what you mean when you say I'm in my yellow zone for COPD. And they can get you on treatment, whether it's an antibiotic, whether it's steroids, in the yellow zone. Because what we want to prevent is we really want to prevent you getting to the red zone, okay? So your symptoms of your red zone are you're really struggling to breathe. Your skin might be pale or gray. Your fingertips are blue or your lips are blue. It's really hard to walk and talk. You're confused or agitated. Any of these symptoms, really you need to take your relief medication right away. First lip breathing, which I'll teach you how to do here shortly, and you need to call 911 or seek medical care because you're to the point in time where you probably need to be seen in ER and might end up with a hospital admission. So what are some of the treatments for COPD? So our first, kind of one of our main treatments is a bronchodilator. So bronchodilators are medication that really kind of help you relax your muscles around your airway. So as you start having trouble, you're coughing, you can take a hit of your bronchodilator, whether it's a nebulizer or a inhaler, okay? Some examples of bronchodilators, and there's actually quite a few, even more than what I have listed here, so I'm not going to read through everything, but albuterol is probably the main one that you see. Some of the generic brand of albuterol is Ventolin, ProAir, itraprobrium, which is Atrovent, Zopinex. These are all short acting, so what that means is that you're going to take a hit, and within probably 10 minutes, you're going to see relief from that medication. The ones that are long acting, these are ones that are kind of more for control for a long term of time. So these are ones that usually patients take on a normal basis every 12 hours or so. So they kind of build up in the system and they last for that whole 12 hours. Where the ones that are short acting actually are pretty much out of your system probably within about 20 to 30 minutes. So from there, we usually do an inhaled steroids, and the doctors probably will step you up. So they might start you off with a bronchodilator. If that's not controlling you any longer, they might add the inhaled steroids. So two of the main ones that you kind of see are the Flovent and the Pulmicort Flex inhaler. Those are the two big ones. So what the inhaled steroids do is help prevent that inflammation. So even if you're feeling super, super good and the doctor has you on inhaled steroids, you still want to continue taking it because you want to keep that inflammation down because that will decrease your amount of times you'll have that exacerbation. And that's the same for emphysema and for asthma. From there, you might do a combination drug. So combination drug usually has a bronchodilator and a steroid and kind of put together. You kind of see all the different names that we have here. And then once you are past the point or you're in that yellow zone, they might add things like an oral steroid. These are something that should not be used long-term, where an inhaled steroid's okay and safe to use long-term, and oral steroids not necessarily. And then they might give you that antibiotic if they're thinking that you might have a respiratory infection. So this brings us to some of the lung therapies that you might see. So oxygen therapy. So basically, if you're not getting enough oxygen, which there's some tests that the doctors will do to see if you qualify. So you can get some oxygen. So some people with COPD use oxygen just while they sleep. Some people with COPD use oxygen just while they're getting up, walking around. And others have to use it all the time. So it just really depends on the severity of your disease process. And oxygen therapy actually really can improve the quality of life. I actually was just with a patient within the last half an hour, and she was really nervous because the doctor had prescribed oxygen for her, and she was afraid she would become addicted to it. You can't become addicted to oxygen. Actually, we're probably all addicted to oxygen because we need oxygen to be able to survive. So if your body's low on oxygen because of your disease process, then oxygen is what you need to be able to, one, stop the disease process a little bit, and two, just to make you feel better. Pulmonary rehab. This is one of my passions. I love pulmonary rehab. That's actually where I'm at right now, is working at our pulmonary rehab department. So pulmonary rehab for those patients that qualify, that have emphysema. We even have some asthma, chronic bronchitis patients. Pulmonary rehab is something that your doctor can prescribe to you. It's a 12-week-long program that we have you come in, and we put you through some series of exercises twice a week, as well as some education classes. And literally, we have patients that will come in on day one and barely able to exercise for 6 minutes. And a lot of them, by the time they're done with the 12 weeks, are exercising for 60 minutes at a time. So it is a phenomenal program to help build up your endurance, to help you learn how to manage your COPD. We can't cure COPD, but we can help you manage your COPD and help getting you feel better so you feel like you have a quality of life out there. So a couple of big relaxation techniques that you might use are pursed lip breathing. So pursed lip breathing is kind of where you do sit nice and comfortably. People say that yoga is blah, blah, blah. Yoga actually has some really good breathing techniques. So this is one of the ones that you can kind of do. So you're going to sit comfortable, your muscles relax, your shoulders relaxed, okay? And you're going to inhale through your nose to a count of 2, like you're smelling roses. You're going to exhale through your mouth like you're kind of blowing out a candle for a count of 4. Kind of what this does is kind of twofold. So if you can think of, I talked to you earlier about how your airways kind of get swollen and floppy because of emphysema. If you kind of think your airways are swollen and floppy, kind of like this. So what the pursed lip breathing does is it allows those airways to stay open like this versus being floppy when you're trying to breathe in and out. So that breathing against it allows the airways to stay open so your air can travel through. Okay? 2, it makes you conscious of what you're doing as far as your breathing. You have breathing problems, the first thing you do when you start being short of breath is you tense up. Okay, well, what happened when you just tensed up? I just took my lungs that were nice, big, big, big organs, and now I just scrunched them up nice and small. So what this does, by opening your chest and making you focus on your breathing, really helps learn to control, and it will help decrease and help you recover much quicker after doing some exercises. So kind of, I have gone through pretty much most of my presentation. I can probably take some questions, but what I put here, and I know you guys have a copy of this, is really, these are some great resources. The lung.org is phenomenal resources for you guys. The COPD Foundation, both of these links are great tools. If you have questions, I highly recommend that you get on either one of these and kind of read through it. So next time you go see your doctor and you have questions, then by all means, you kind of know what to ask them, okay?
I'll pull up the chat bar for questions.
He's going to take over here.
Yeah. Okay, what questions do you guys have? I'm going to kick it off with one I'm kind of curious about. Amanda, with purse lip breathing,
Yes.
when would you do that? Is it something that you have to practice every day to get the benefits from it, or is it only when you're concerned with a flare up?
That is a great question. Actually, you should be doing it every day. And weirdly enough, your body over time is actually going to start doing that on a natural basis. So when you start having trouble breathing because you got up to go, cook dinner, you got up to go to the bathroom and you're getting that shorter breath, you'll find yourself doing that actually pretty normal basis. But if you consciously think about it as you get up to do things and things start becoming shorter breath, then it just becomes more of a natural tendency when you do start doing active.
Okay, and the process is twofold, to kind of relax you and to focus on
your breathing.
Okay.
Yep. Great question.
Let's see. Are there other questions out there? If you can type them, or you can take yourself off mute. We can try it that way too. I'm open. The technology is not my strong suit either. If someone is struggling with asthma or COPD, should they get a referral from their doctor for pulmonary rehab, or is that something that they can self-refer to?
Nope, that's a great question. It has to be from a physician. Medicare, that's a requirement for Medicare. It has to come from your primary care or your pulmonologist, whoever you see.
And what types of exercises and activities do you do in pulmonary rehab?
So we have a treadmill. So we have them walk on a treadmill. If treadmill is too hard because you use a walker or something like that, we do have a track we can have you walk around. We do arm exercises because as I told you before, you stop breathing with your diaphragm, you start breathing with those upper muscles. So what the arm exercise does is help build those upper muscles to make breathing easier. We have a bike. We have 3 different types of bikes that we might have you ride on. And then we have what they call a new step. So a new step is kind of like a stair stepper, but you're sitting down. So it's not quite as cardiovascularly stressing as what a stair stepper would be. And then as the program goes, like I said, we start you small, and as the program goes, we actually increase the amount of exercise. But it is kind of like what's the word I'm looking for? We work together with you. So we kind of say, hey, tomorrow when you come in, or on Thursday when you come in, what piece of machine you want to increase a minute on? What piece of machine you want to increase the resistance on? So we never want you to be stagnant. We always encourage to increase, but we always kind of, work together between you and the therapists that are there to increase the program.
Yeah. So I could see if you're at home and you're struggling with asthma or shortness of breath, starting exercise could be really scary. Do you find that a lot of your patients are very apprehensive when they come in to start exercise program?
Very much so. We actually, the very first program, or the very first visit, it's about an hour and a half long visit, because we have found that really helps decrease their anxiety about coming. So we really do a pretty in-depth interview. We kind of really reassure them that this is possible, because it's hard when you're at home and you can't breathe. And the last thing you think I can do is go walk on a treadmill. In your head, you picture that 20-year-old with a bikini running on the treadmill at 10 miles an hour. That's not an expectation. And what's really nice about the program is that people build lifelong, friendships from it, because you're exercising and you're with people that have the same disease process as you. So you're not in it alone. If you need oxygen, we have oxygen that's piped into the wall, so you don't have to worry about, carrying your oxygen tank around with you, walking around the mall, things like that. So it's definitely a great program.
Yeah, and for the social aspect too.
Mm-hmm.
So for those who are at home and maybe don't have access to this or have transportation issues, if they were going to get started with exercise, at home with their doctor's permission, are there certain activities that you would suggest as a better starting off point for someone?
Yes, I always encourage patients, even in the hospital. I primarily work at the hospital, so I have patients that's in the hospital. I encourage them, you like to watch TV at a commercial, get up and just walk in place. Walking in place for that 3 minutes at a commercial through your whole favorite TV show that's an hour long, believe it or not, that's probably 20 minutes of exercise for you to do. And that's sufficient for the very beginning to start. Soup cans, or even at the beginning, a water can, a water bottle, sit in a chair and just do arm exercise and lift it up. And that is something we include in the program too, is we do home exercise and we give you stretchy bands and things to encourage home exercise. Anybody here is computer literate, you can Google or exercises for COPD. And I'm telling you, there's YouTubers out there that have specific things that they can just sit and do at home in a chair. Anything just to get yourself moving.
And
be sitting there.
Yes. And so when you get moving and you start increasing your physical activity, you might find that you get short of breath more often. Can you tell us about some of the benefits of exercise long term with when someone starts pulmonary rehab at the end of the course of treatment or at the end of a course of exercising for 3 months? What are some benefits that people typically see?
Well, a lot of our patients, believe it or not, a lot of our patients do end up off oxygen because just that, getting them up physical. I always like to tell patients, if you think about way back when you were a teenager, for example, I have a son that is a runner, okay? He's run several marathons. If he goes 2 weeks without running, he's almost back to square one. Even at, 17, 16 years old, you go a couple weeks without doing physical activity, cardiovascular, you're back to square one. It's no different when you're, 50, 60, 40, 70, 80. Anything that you can do to get your heart pumping, your lungs working is better for your body. So I really see the benefits of the patients. One, not only psychologically, do they know they can do more, but they physically can do more because they feel better. So really, for a finger, the question was any recommendation or guidance to use a fingertip pulse oximeter at home. There's technology has changed so much, and there's so many good ones. I would definitely, if you're going to think about purchasing one from like Amazon or something like that, make sure you're reading, the comments to see how accurate it is. My biggest thing when patients have one is that take it to your physician's office the first time and make sure it correlates with what the physician's office, the medical grade one is, to make sure that it's right. And the biggest thing you can do is don't obsess with it. I mean, you cannot obsess with watching what your oxygen level is doing every single second of the day. So if you're short of breath, fine, put it on and see where your oxygen level is at that point in time. And you trend it. If you track it and you see that you're dropping, to 84% every single time you get up to go to the bathroom, and that's something you need to discuss with your doctor because you could potentially need oxygen along with it. So there's a lot of really good ones out there nowadays, but I would probably check it, just more for symptoms. If you start feeling short of breath, check it. But I would really recommend that you go take it and you have it correlated with your doctor, so you know that it's a good oximeter and not just a cheap, knockoff that you bought.
What are some other things? So other than the oximetry, what else do you assess or could you assess as part of intensity?
What is so hard, I think, sometimes with COPD is so patient dependent in the sense of sometimes I'll look at a patient that is, on the treadmill and they look horrible. I think, and I need to stop them because they look so bad. But I ask that patient, how do you feel? Oh, I feel great. So it's really, you really have to learn how to self-assess yourself. You really do have to know when your limits are, okay? And you have to learn to pace. If you have COPD, you shouldn't go out and walk 5 blocks the very first time you decide that you want to exercise. Your first exercise literally might be walking to the end of your driveway and back, and that's okay. That's completely okay. But you have to learn to self-assess your symptoms. When you get to that point where this is hard, okay, this is when I need to stop. I need to work on my pursed lip breathing. I need to pull up a chair. I need to sit down. I need to relax. And then next time you try something, go a little bit farther and see how you do.
do you see any patients that have COPD that's related to their allergies, or is that more limited to asthma flare-ups exclusively?
Great question. Asthma is more allergy related. Now, that doesn't mean you can't be diagnosed with COPD and have like an asthma flare-up with the COPD. So you could kind of have both, as you get older, for sure. Typically, in a child, you're not going to have the COPD aspect. It'll be more of the asthma.
I know we probably have a few people listening that might have emphysema or I think cystic fibrosis might have been the other one that you mentioned.
Yep.
Any advice for individuals with emphysema starting with exercise, or any special considerations?
You're listening to your body. That is the big thing. But like I said before, anything that you get up and do is better than just sitting on the couch thinking you can't do it. By all means. I say start small and work your way up. We really encourage the walking, because I think that tends to be, weirdly enough, probably the hardest for a lot of COPD patients, because if you really think about it, your muscles are your biggest, or your legs are your biggest user of oxygen because you're out moving. So, even if it is walking twice around your living room for the first time, and then eventually start adding more of like the arm exercises. So if, you have the cans of soup and you can just lift your arms above your head. I know Katie's going to do a little exercise series with you. I'm sure you got some sit down exercises that you can do. Any of that type of stuff is phenomenal. And it's helpful because what it does is help you learn to control your breathing, which that's really what you have to learn with COPD. We can't cure COPD. We can't fix the damage that's already been done to your lungs, but we can definitely, COPD is manageable to be able to learn and you can have a very normal life with COPD.
Great advice. Yeah, that's really good. Well, thank you so much for sharing with us today.
Thank you.
It's really good advice to start small, listen to your body, and don't get discouraged. If you feel like you need to stop and rest for a few minutes, you can always get right back to it.
I have to stop and rest.
That's awesome.
Yes, thank you.
Thanks for joining us all today. I apologize for our disconnect there. I'm thankful that you guys hung with us so we could pop right back on, but we'll look forward next week to learning a little bit more about tips for kind of getting through the ups and downs, some positive psychology advice from one of our social workers, Amy Romaine. So I hope you'll join us next Tuesday, September 1st. It's a really good talk. Amy was one that I was really hoping to get for this year's Senior Health Series. So I'm excited to share some of what she has her perspective and tips for kind of coping with the ups and downs of life and positive thinking. So thanks again, and I hope I see y'all next Tuesday. Bye.
Thank you. Bye.